Good morning. My name is Reza Azizi. I'm an emergency physician and an EMS medical director in Southern California. I have the distinct pleasure of being the moderator for our first question and answer session with our speakers who presented their information just for you and you viewed. I'm just going to jump right into a couple of the questions. And the first one actually goes to Nicole in regards to the LA County experience. And a lot of question comes up for EMS systems about the choice of an LVO assessment tool or the LVO screening tool. What was that experience for you in LA County, and what comments do you have for others who may be at same junction?
Hey Reza, it's Dr. Schwam. Your audio is coming in, at least for me, very choppy and like hard to hear. I don't know if that's true for others.
Is that true for others?
Yes, Reza, I'm sorry, I was just texting you. I think you've got a little bit of feedback, so.
All right, let's see if we can fix that.
But while you're working on your audio, I'm happy to try to answer that question. Thank you so much. So in LA, obviously we use the LAMS. It is the LA Motor Score after all, so it would be a little strange if we use something different. There have been studies looking at the performance of different stroke scales in the field. I think the most recent and comprehensive is the publication from Dr. Huyen in JAMA last year, which looked at 7 different scales and found them all to be fairly similar in terms of their performance, with decent sensitivities and specificities, although the LAMS and the RACE did perform slightly better than other scores. Feasibility is also an issue, and training. Some scales are more complicated, but may then perform better. So in EMS, we always need to balance that. I think the reality is, and perhaps Dr. Klingman can talk to this as well, because I loved his recent publication, although was a bit scared by his recent publication, thinking about how EMS systems are going to navigate this idea of identifying LVOs accurately and transporting them to CSEs. It seems like we still have a ways to go in regards to really good accuracy at identifying patients with LVO, and there's still going to be patients who have low severity scales that can benefit from this therapy. And then there's still going to be some over triage as well with the current tools we have. But training EMS on more complex scales, such as the NHSS, to complete a full scale in the field would be very challenging. So I think it's a balance there, and I turn it to my colleagues here to weigh in with their thoughts.
So Dr. Klingman, Nicole kind of threw you into this question. Did you have any quick comments on the same question? And by the way, is my audio any better? I'm sorry.
Yes.
Okay, fantastic. Thank you.
Yeah, I hope I come through okay. I'm in the wilds of Alaska, actually, in a cabin. So I think the challenge is, I'm not sure that any clinical scale is going to be necessarily any better than any others. So hopefully there'll be some technology fixes that come along that are able to help this out. We looked at the whole NIHSS with stroke neurologists and found that we're still not all that great at identifying candidates for thrombolytic therapy. We can do pretty well, right? We're doing the full assessment, but even so, you'll see somebody that comes in and you're absolutely convinced they have a large vessel occlusion, and you get the CTA and they don't, which is why I was sort of advocating in the paper that regardless, we really should improve this performance of the primary centers and the transport system as a sort of key metric on how to make the whole thing work regardless of who walks in.
Excellent. Thank you for that. I want to turn over to Dr. Schwam and his presentation. And the question comes up regarding the distinction between thrombectomy centers and comprehensive centers. And I think in Nicole's system in LA County, for the purpose of EMS transport, they treat them equally, because most of the EMS triage tools are designed to identify large vessel occlusions. And we think that majority of distinctions between thrombectomy capable centers and comprehensive centers really lies in hemorrhagic events. So I guess the question would be in the context of your presentation, how do you recommend that systems look at thrombectomy only centers and categorize them versus comprehensive centers? And what recommendation do you have in terms of EMS transports to one or the other?
Yeah, I think it's a nice follow-on question, and I agree with both of my predecessors here, Nicole and Dr. Klingman. I think we have to recognize first and foremost that no pre-hospital scale is going to perform at a level of discrimination that we would like. So we're going to have to accept inaccurate allocation. So then you have to ask yourself, where is time your friend and where is time your enemy? So if you triage somebody to a place that's further away in a time-sensitive condition, the risk is that they will be harmed during that window of transport and potentially even miss an opportunity for treatment. If you think about hemorrhagic stroke, certainly in the setting of subarachnoid hemorrhage, minutes don't count for most patients unless they have acute hydrocephalus. Most patients can be safely retransferred to another facility or stabilized at the initial facility, particularly if it was, say, a TSC. The real question is, the main difference between TSCs and CSCs, at least in the Joint Commission certification criteria, is, as you said, the care of subarachnoid hemorrhage patients and large intracerebral hemorrhage patients. So if the thrombectomy care is really equivalent, you're asking yourself, is the extra distance worth whatever operator difference there might be in terms of procedural volume and capability and potentially aftercare? You can still transfer the patient from a TSC afterwards if they have complex care and need a dedicated neuro ICU with neurointensivists. So I think the proper place in the stroke system of care for TSCs is in areas where there are no CSCs, because they can't meet the volume requirements for aggregating enough patients with hemorrhagic strokes. So urban areas should have CSCs. They'll probably have more than one, just based on how our medical system works in the US. And you ought to go right to one of those. If you're in a rural area, you ought to go to the nearest thing. If you can reach it within 60 minutes in a CSC, that's great. If there's a TSC that's closer or within that 60-minute envelope, great. If you can't, get to the nearest hospital, get stabilized, and as Dr. Klingman was saying, get treated and transferred. I think the real challenge is in the suburb, where you've got a TSC, in the outer ring, and you have a CSC in the inner core. And where you go to get your care there, I think ultimately should be driven by performance characteristics of the individual hospitals, which should be a matter of publicly available reported data for EMS agencies and potentially the public. And then, as I think Dr. Klingman was alluded to, let the algorithms figure it out. Let them look at traffic patterns, NIH stroke scale, time since onset, door to needle time at the nearest hospital, door to needle time at the furthest hospital, door to puncture time at both, and let an algorithm optimally match you to the destination of choice, and then allow patient preference where appropriate to play a role. So long answer, but complex question.
Yeah, I appreciate that. It's actually very thought-provoking, a lot of questions to really consider carefully. And clearly one answer, one size does not fit all, and that has to be considered. Dr. Klingman, do you have any follow-up comments on that question itself that Dr. Schwam answered?
No, I think that's exactly right on, which is you cannot design a system without knowing all the data. So unless you know what your performance is at the center you're going to for an endovascular treatment, you can't really tell. There's been some really interesting modeling done from University of Calgary. Sort of what they point out is that if you can get your treatment within 30 minutes, it makes a lot less difference which facility it's and also your door in, door out. We do need to keep in mind that the number of actual endovascular treatments is considerably less than the number of thrombolytic treatments.
Yeah, I just want to jump on that, Rez, with one last point,
yes.
Which is, first of all, we know that a perfect screening tool, 99% sensitive, 99% specific, with a 5% prevalence of stroke for all EMS transports and a 1% prevalence of LVO. If you think LVO is 20% of stroke, means your positive predictive value, meaning I think it's an LVO, never going to get better than 50% and will probably hover more like 25%. So agree totally with that. The other thing is ultra early thrombolysis is not a linear curve. It is probably exponential. So we're seeing 20 to 25% recanalization rates in Extend IA-TNK and then recently in RaceCat, which hasn't been published yet. But in the mobile stroke units or in scenarios where you're treating even, in that first 30 minutes, 45 minutes, MCA recanalization might be as high as 50%. So I think, we have to strengthen the primary stroke center network. We have to keep having patients go there to get, I think, TNK most likely, as in anyone with a major stroke syndrome where LVO might be suspected, in, out. And if you had TNK, as Dr. Klimming was alluding to, maybe a BLS truck is all you need, because it's all about time and not about trying to further refine diagnosis in a situation where the tools will never be good enough.
Fantastic, gentlemen. I appreciate those comments. Let me just quickly change a little bit on the topics. I want to turn over to Lindsay here, if I could. This path to comprehensive designation can be quite stressful and anxiety provoking for many of the centers, especially if they have competing service lines that really compete for the same resources in the institution, namely the emergency department, and their ability to quickly identify, route, prepare patients for a stroke intervention versus cardiac intervention, for example. So I wonder if you can focus on that, and how do you recommend institutions with competing service lines to be able to develop a successful stroke treatment program?
That's a great question. And I think it all comes down to collaboration rather than having competing service lines working together. A lot easier said than done, obviously. But in our case, in San Diego County, we do have a number of health systems that have successfully worked together, not only with emergency medicine, neurology, neurointervention, neurosurgery, but also with trauma. We do have in San Diego County, at a lot of our health systems, we do have a combo trauma stroke code, where oftentimes it's cited as conflicting whether EMS should designate the patient as a trauma code versus a stroke code. At a lot of our centers in San Diego, we have a combo. So we work together, ruling out the trauma, ruling in the stroke. I think similar sort of ideas need to be placed on other service lines as well. And the more we work together, we all are in it for the same reason, with the patient at the center. And if we can all work together and come up with time-effective processes, then we all achieve a common goal. So that is my recommendation on things.
Great, Lindsay. What about a realistic timeline? Do you recommend hospitals to start looking at this at a certain time interval and don't anticipate miracles or fast track processes? What does that timeline look like?
The timeline is a lot longer than you would anticipate. So there needs to be quite a bit of preparation in going from a primary stroke center, not only to a comprehensive, but also in consideration of a thrombectomy capable stroke center. There are a number of things that will need to be put into place, not only process, as I discussed, but also looking at outcomes. So simply thinking about, two major things that hospitals often cite as issues is developing a research protocol or research department, getting the support for that. And then also the ability to take care of complex patients simultaneously. That takes time. If you have one biplane and need to have a second suite to take care of patients, that's not going to happen overnight. So the preparation and the gap analysis needs to start at least a year in advance from what I've seen, if not a little bit longer.
Excellent. Thank you, Lindsay. I'm going to turn over to Dr. Klingman here, if I could. And actually, there's a question on the question and answer regarding the use of 911 system for these IFTs. And I'm assuming what they mean is, instead of calling a transport provider usually a private ambulance company, to provide a transport mechanism that you actually dial 911 from within the hospital, and 911 shows up under the same clock. And if you're not medically prohibited on making the transport, given the expertise of an ALS unit, you could do that. I know you recently did some work on this with Kaiser, and you and I have talked in previous presentations on this. I'm wondering if you're aware of other places in California actually do this. And in general, I kind of want to ask you to talk about your recent publication and what your general feeling about this direct field transport to primary stroke centers or thrombectomy capable centers versus the IFD model. And where do you think ultimately is going to be the more practical solution for most systems?
No, it's a fantastic question. Hopefully I'm unmuted. Oh, good. And I don't cut out again in the middle of the answer. But we actually, in one of our areas up in Roseville, they actually using 911 regularly. And it is not unusual to get the patient out of the door in less than 60 minutes. So 911 is highly successful. The concern, of course, is the 911 system. It takes a rig out of circulation, and there's a lot of concern about, well, if we take this rig out of circulation to go to the comprehensive center, then it's not available for other emergencies. But if you look at the actual number of transfers for identified large vessel occlusion, it's a pretty small number. I think we, in our system of 4.5 million people, we did something like 300 EST cases. So it's a really small number that gets transported. So I would argue that I think a really interesting way to think about this is to use that 911 provider if you are able to, because you're using, for example, Connect-A-Place, which is a one and done. Now, it doesn't work for everybody. People go on antihypertensive drips. They cannot be transported by 911. People are medically unstable, can't go by 911.
Oh, I wonder if Dr. Klingman will pop back on. Last time he did, but we can't be lucky twice, right? That's what happens when you call in from Alaska. You know, Dr. Schwam, I think you come closest to potentially maybe an opposing view on that, maybe differing a little bit. Maybe I can get you to comment on that based on what I think we've heard so far from Dr. Klingman.
Well, I'm not sure. You know, I think restate the question for me and lead me in the direction you think I was going to go.
Well, I think Dr. Klingman's perspective that I've spoken with him about is, oh, here he is. Are you on, Dr. Klingman? Can you hear us?
I think his bandwidth is pretty limited. You might want to keep talking.
Yeah, so the conversation is about field transfer, direct triage versus interfacility transfer methodology. And I think some of his recent work at Kaiser has really seemed to have focused on the success, at least in his system, of interfacility model, and highlighted some of the significant challenges with direct transfer from the field. So I think that's what the conversation is.
Got it. Okay. Yeah. I mean, I think the right answer will disappoint the politically radical in the audience, because I don't think it's actually polarized. I think the real answer is depends on the conditions and the environment. So, for example, in Kaiser, where they have an integrated delivery network, they have a shared health record. They already know lots of information about the patient before they arrive. So they know their health history. They know if they're on anticoagulants. They're optimized for rapid decision-making. And as he said, no need to print a CD, no need to send the images, no need to send the record, right? So they really are primed for that contactless experience. You know, come in, PPA, yes or no, telestroke if you don't have a neurologist, TPA, go, and EVT, go. And I think that in systems like that, where you can leverage a primary stroke center network and you have adequate distribution of sites with respect to population density and a hub comprehensive or thrombectomy capable center that's readily accessible to you, I think there's no question that that has been demonstrated to be a highly effective network. Now, if there's a CSC 15 minutes further down the road than a primary stroke center, and the LAMS or the race score is, at the top of the charts, and the patient has a classic, say they have atrial fibrillation, they're on anticoagulation, and they have right hemiparesis and aphasia, should you go to the primary stroke center first? From an optimal patient-centered perspective, probably not. The yield is probably high enough in that population of patients that you probably ought to go direct to the comprehensive center. So I think it's really hard to answer these questions in the abstract, because the debate is only meaningful when you're looking at a specific geography. If you've got 15 primary stroke centers all near each other and one hub that's an hour away or an hour and a half away, it makes no sense to go directly to the comprehensive center, because at least 7 times out of 10, there won't be any different treatment by the time you get there, and you will have spent a lot of money, pulled a lot of crews out of service, moved families away from the patients. So I think that there are penalties to the direct to CSC approach that we have to recognize and incorporate.
Thank you for that. And I know I'm over time, but I really want to give Jeff a chance to finish his thought in that context. So Jeff, if your internet connectivity cooperates, could you finish your thoughts on that same question when you got cut off?
And you may want to just turn your video camera off.
Yeah, I'm not disagreeing with Lee, and I think that really the answer is, oh yeah, let me try that.
Yeah, if you turn off your video camera.
So I want to agree with Lee. I think that basically the answer, yeah, basically I think the answer is it depends. And like in all things in medicine, it depends. And I think that you can't go without a position of data around performance. And I think that Lee's point about
well, so technology is what it is. So I want to thank all of you for participating in this. I certainly want to thank our presenters. At this point, we have a break until 9:25. So you will see a break slide. But again, I really appreciate everyone who submitted a question, and I appreciate our presenters for making the time to be here with us and discussing these issues. We'll see you after the break. Thank you, everyone.
Thanks for the invitation. Bye, everyone.
Bye, thank you.